insightful feedback were truly inspiring. As we continue on this conference journey, let us revalidate our dedication to excellence in healthcare and a passion for long learning. Our next session is joint ventures, the fracture of hand anthroplasty. I now invite our esteemed chairperson, Dr. Sudhajit Sen, Dr. Vikas Gupta, and Dr. Ramesh Chanagiri to take the stage and moderate this expert discussion. Where is she? Where is she, Sonali? Come on. Where are the coordinators? The coordinators. ಇವಾಗ ಡಾಕ್ಟರ್ ಕೋಆರ್ಡಿನೇಟರ್ಸ್ ಇರ್ತಾರಲ್ಲ ಅವರಲ್ಲಿ
Good afternoon, all. Welcome to this session on the futures of hand arthroplasty. To start with, we have Amit Putty talking about Valant Revolution, Advances in PIP Arthroplasty.
Good afternoon. I think we've had a really good discussion so far, and I think this session I'm hoping should be good. So, why Valant? Valant, as we all know, is wide awake local anesthesia, no tourniquet. It gives a relatively bloodless field. The patient is able to participate. He's actually with you, he's listening to you, he's talking to you. You can talk to him about the rehab. You can actually check implant fit because he's actively moving his fingers. And I've been doing this for about 11 years, so I think I'm maybe quite a bit biased towards Valant now. What are the contraindications for doing Valant in PIPJ? And it's mainly a peripheral vascular disease, Raynaud's, and if they have very significant cardiac issues. So if they have hypertension, if they have any other cardiac issues which is well treated, I wouldn't necessarily say I won't do it. But if it's only very, very significant cardiac issues, that's when I would stop offering them Valant. So how do I do? I normally use about 1% lidocaine, and it comes pre-packed at least to us in a 1 in 200,000 solution. In fact, we had some supply issues in the last 4 or 5 months, and they've been giving me 0.5% lidocaine, and that's worked absolutely fine as well. I think the trick, what most people say and what I have found is you have to inject at least 30 minutes before. And this is how the finger will look. You can see that there's white blanching in the finger, and I put in maybe about 8 to 12 mils. And I do it preoperatively while I'm consenting them. By the time the patient's changed, all the paperwork's done and come through, it'll be nice and clean. For the PIPJ arthroplasties, I do a dorsal approach, and you can see that after the first 30 seconds, once you probably need to use your bipolar cautery maybe about 2 or 3 times, but after that, it's relatively bloodless. And I do a central slip split, and I just elevate it, and just your standard procedure. You excise your osteophytes, oscillating saw for the proximal phalanx, and I use the burr to open the canal up. And follow the surgical technique, do your rasps, and then I use the various trial implants and I put it in, and I ask the patients to do the active range of motion. And one of the reasons why I thought I will switch to Valant was because in the initial stages, I wasn't sure when I was trying to move it passively, have I put in too tight, or is there stiffness post-operatively because I have put in a bigger implant? But when I put it in and I get them going, the patients will actually tell you, oh, this size feels better than the other. Now, one of the things they'll say is, I'm not sure if I'm moving my finger, but I always tell them, you can touch your palm, and now you tell me which size feels better. So you can actually trial different sizes. And I can also check that they are having full range of movement on the table. So this is a case I did on Wednesday, and you can see that preoperatively she's got a fixed flexion deformity of probably maybe about 40-45 degrees, and a further flexion to maybe about 60-65 degrees. So quite a stiff finger. Pain was a significant problem. Intraoperatively, and I hope this video plays. So I usually don't stop until I have got a full range of movement and they are able to touch the tip of the palm to the tip of the finger to the palm. So and the reason for that is because they do tend to stiffen up a little bit. This is my series over the last 10, 11 years. The series I've looked at is only celastic implants, and it's using Valant. 42 cases, 29 women, 2 men. The indication in all of those was primary osteoarthritis, and the commonest fingers were middle and index finger. Because it's primary OA, the mean age obviously is on the higher side. Post-op DASH scores was 24, and that means, yeah, they do get satisfactory outcome. They don't get excellent or good outcomes as such, but I always tell them that the main reason for your arthroplasty is pain reduction, not your hand's not going to be normal. VAS scores is a significant improvement, and one of the things which I found very, very satisfying was the increase in the range of movement. Most studies say that they don't get as much range of movement, but I don't know whether it's to do with Valant or whether it's to do with the fact that they're able to move it. Intraoperatively, it's usually 5 to 90 is what I try to achieve, or 0 to 90. They do stiffen up a little bit, and then they stabilize, and they usually get a range of movement of roughly about 60 to 70 degrees. Complications, I had 3. One was superficial infection, which treated with antibiotics. There was a patient with persistent post-op pain. Not sure what the cause was. I had to change it to an arthrodesis. And one swan neck deformity, which needed splinting. I've published part of our series, and it was the first maybe 29 cases, and then now we've done a few, so hence the increased number of cases that I've got. I am a big proponent of Valant, and I would say to most people, do it, try it. I do carpals. I initially started off with carpal tunnels and triggers. Now I usually do sonosurgery, so incisionless, scarless, ultrasound-guided technique. Then extensor tendon repairs work really well. Flexor tendon repairs, I think you see there's no gapping when the patient's moving it actively. One of the best things I love doing with Valant is derotation osteotomies. You can do it and you show the patient. The patient looks at it and he tells me, oh, I like this doc. I can already see it's corrected. And then I put the patient on the spot, literally saying, so are you happy with this? Can I fix it there? So he doesn't come back post-operatively and complain about it. Now, I've also started doing trapeziectomies and simple deputrance, but the simple deputrance is the patients who do not want a needle fasciotomy, but they're the ones who say, I want everything taken out. So those simple deputrance I would do Valant with. So take home message, I would say to everyone, try Valant. You might not like it, you might like it, but unless you try it, you won't know. It's really, really useful, and I think I have pretty much eliminated my anesthetic needs or anesthetist for anything metacarpal and beyond. Thank you.
Thank you, Amit. Any questions from the audience for Amit?
So it's a question about how practical it is in terms of timing your injection, because I always struggle to get in 30 minutes before, because I'm operating on the previous patient at that point in time. And so I don't get that blood dystrophy initially, and that 30 minutes happens during the operation. So I don't know if you've got any tips of how we can overcome that challenge.
So when I say 30 minutes before, I think it's minimum of 30 minutes. If you have injected an hour before and you start operating, it's still quite relatively bloodless. So it's not that it starts bleeding. I think it probably works for up to about a couple of hours. What I do is, if I'm doing a list of locals like carpal tunnels or trigger fingers, I'll inject first 2, then I'll go in, I'll operate on the first, I'll come out, I'll inject the third, operate on the second. So there's always one patient who's waiting to go, and I've got another spare patient in the bag, as if I can say that. And most of the procedures that I have done in the Valant, they would take me less than an hour, for including trapeziectomies, derotation osteotomies, all of those, I would say are less than an hour procedures. So timing is I've not noticed that to be a problem. And even if it's that I have to start an incision about 50 minutes after I've injected, I've not noticed it bleeds a lot.
Yeah, I agree. I mean, the timing is good, but it's not essential, and you can operate much sooner, and then it kind of stops while you're doing the operation. Thank you.
Well, thank you, Amit. You've dropped the carrot, so it's for people to try and see if it works for them or not. Thank you.
Thank you.
We've got Shudhajit Sen next, young and resilient arthroplasty in post-traumatic PIP osteoarthritis.
Good afternoon. Thank you to the coordinators, moderators here, and the organizers to give me this opportunity to talk about it. Post-traumatic PIP arthritis is not the bulk of my practice, because most of the PIP arthritis I operate on are osteoarthritic. However, I've got very little experience of doing it for post-traumatic arthritis, and I'll try to share whatever experience I've had. No conflicts of interest, no sponsorship received. So, prevalence. Small joint osteoarthritis is the leading cause of hand surgery. And if you look at the incidence rate, then thumb CMCJ takes the cake, the cherry, and closely followed by DIPJ arthritis, where we see mucous cysts, patients coming with them, and it is followed by PIPJ. MCPJ is the least common form of osteoarthritis, unless you're suffering from something like hemophilia, where you get isolated MCPJ arthritis. And female to male ratio is about 3:1. In females, we do see complete joint destruction, which makes the procedure more tricky and the condition more painful, apparently. However, if you come to post-traumatic, it's different. So PIP is a fantastic joint. It has an arc of motion from 0 to 110-degree flexion, which allows us to do most of the things. It accounts for 85% of the fingertip excursion. It's a bicondylar hinge. It has a thick volar plate and 2 collateral ligaments with proper and accessory components to it, which are absolutely paramount for coronal stability. And the functional arc of motion, which is very important for us when we decide about arthroplasty, is 30 to 70 degree of flexion, which allows us to do most of the things with our fingers. Post-traumatic PIP arthritis, demographics is mostly male, and it's not a very well-defined condition. Why do I say that? Because we've seen post-traumatic PIP joints being destroyed by the trauma, uneven, irregular. However, it's not that painful, or sometimes the pain is not the problem, it's the stiffness. And we all know that preoperative stiffness determines postoperative movement if you're doing arthroplasty. So in a stiff joint, it's difficult to decide to do an arthroplasty. A fusion would be a better procedure in them. And commonly, it is associated with Bottonia and swan neck deformities due to various types of ligament and capsular injuries associated. And then it becomes much more trickier to operate on them. So my surgical preference, if it's a heavy manual worker and radial-sided digits, I fuse. I wouldn't lie about it. A fusion works better if it's index finger or middle finger sometimes. But older, less active individuals, implant arthroplasty is good. Having said that, my small series of post-traumatic PIP arthritis, I've done it in male patients in their 30s and early 40s, and most of them are like, I'm going to the gym and doing heavy stuff. So what implant? Now this is the important discussion here, because in India, you don't have any implants till about a few months ago when Capflex was kind of introduced. So you have CapFlex, and as you can see, I haven't put any cost estimation to it because I don't know what's the cost to Indian market. However, what I do is Silastic, which is Swanson, and I'm carrying on one implant with me for anybody interested to see it. And the cost to NHS is least of these three type of implants available in the market. So pyrocarbon is the most expensive of all of them. So what's Swanson? It's basically a dynamic spacer. It's more like an internal mold. It's a flexible hinge. So it is a single component, and it is like it is not fixed to the bone. It goes through an encapsulation process with time, which allows stabilization. However, we've seen that even when Swansons break, the finger joint continues to work, and is mostly seen in rheumatoid arthritis. So it's kind of a forgiving implant from that point of view. So what approach? I use a dorsal approach because that's how I'm trained and I'm most comfortable. However, if you look at the evidence recently, volar approach gives apparently best range of movement and faster rehab. Lateral approach, which is used in pyrocarbon implants, and Prof. Trail from Wrightington is one of the main proponents of it. It is very good in his hands, but difficult to reproduce. So it's a technically demanding approach because you'll have to go through a collateral ligament and repair it. So in my practice, index finger fusion is a primary option. All other fingers, at least 30 degrees of arc of motion, then I would offer them. I implant arthroplasty. Dorsal approach, preserve the collateral ligaments. If I damage them, then I'll repair them. And it's a very important point. Make a small drill hole, 1 millimeter, in the phalanx and repair the collateral ligaments. Rehab, very important. Outrigger, splint, within a week, they need to see a hand therapist. Without hand therapy, you can't do implant arthroplasty because results would not be good. So this is a common picture of an instrument set which has got various size trial broaches and various size trials. And there is an initiating entry awl that we need to use to make a hole in the medullary canal. And the site of making the entry hole would be 1/3, 2/3 junction between 1/3 dorsal and 2/3 volar. So curved dorsal incision. Now, I have tried the Chamet approach before, where you reflect a triangular flap, keeping the central sleeve insertion intact. But evidence shows that there is no difference in outcome between Chamet and a simple split in the midline approach. So when you split in the midline, it is difficult to maintain or preserve the central sleeve insertion. But if you do a good repair, then usually it works well. But I have seen patients coming back with slight flexion attitude of the finger, and that's mainly because of weakness in the central sleeve. Collateral ligament repair, drill hole in the P1, and then you pass. I use a 2-0 Ticron suture. I used to use a different suture. My colleague, Miss Clement, convinced me Ticron is a good, and it has got a very good needle which passes through a small, tiny drill hole in the P1. Evidence suggests that even if you excise 50% of the width of your collateral ligaments, it does not affect stability. Some examples, on the left, an individual who had also arthritis in the DIP joint, and this is immediate post pictures. On the right, a gentleman with a little finger involvement, and there is some pictures from 6 weeks afterwards. He was moving it well and gone back to the gym. Evidence, Daniel Heron's evidence, hand clinics, 2017, Silastic has the gold standard. And he also mentioned that surface replacement, which is CapFlex, uncemented is the best, and it is demanding technically. However, it's probably best for post-traumatic osteoarthritis. Evidence for Swanson, it's one of the longest used implants for PIPG arthroplasty. In fact, the longest, and it has got evidence behind it more than 40 years. 423 implants were the largest series under Swanson's himself. And other evidence are there as well, which kind of tells us that the outcomes are pretty much similar between pyrocarbon, Swanson, and SRA or surface replacement. SRA, biggest advantage, preserves bone stock and preserves collateral ligaments. Best indicated in post-traumatic PIPG arthritis. And these are some more evidence out there, the jury is out. However, if you wish to know, see how the Silastic implant looks and how it feels, then you're welcome. Thank you.
Thank you, Shudit. Any questions?
So, for if the multiple joints are involved, how you proceed, especially osteoarthritic, when MCP, PIP, and DIP are involved within deformity, like you showed. So, how you proceed?
DIP joint, they don't have any implant arthroplasty. Nobody has done them. So I know some surgeons who tried putting a small silastic in DIP joint, but I don't believe that works. So for DIP joints, if it's painful, then fusion is the only thing that you can offer. Now, in rheumatoid arthritis, we see multiple PIP and MCP involvement in the same finger, and you could try putting 2 silastic implants. I don't know. Have I done any? Probably no. I haven't done in the same finger. MCPJ, yes, straight away silicone arthroplasty, because MCPJ silicone arthroplasty in rheumatoid works very well. PIPJ, most rheumatoid PIPJ are not simple arthritis. It's usually associated with either Bottonia or swan neck. So you will see that their range of movement is minimal, but they are also sometimes painless. So you may not have to do anything about PIPJ in them. If it is painful, then probably fuse the PIP and implant arthroplasty for MCP. That would be my probable rational approach.
Thank you.
If no questions, then we'll move to another next talk.
Thank you.
Thank you. So next talk is by Dr. Chris. He will be talking about mastering the PIP joint arthroplasty techniques and innovations.
Good afternoon. I'd like to thank the organising committee for allowing me to give this talk, and hopefully I'll give a slightly different opinion about the surface replacement arthroplasty. I don't have any declarations. A lot of this has been covered by Dr. Sen before me, but for arthritis, the options are going to be either a fusion or an arthroplasty, or some patients come in asking for an amputation, but I try and talk them into one of the two before. As we said, fusion is reliable, it's lasting, and it's good in young people. But often patients have arthritis affecting the distal interphalangeal joint, and so a fusion is not going to be as helpful. We've already talked in the last talk, thanks very much, it's covered a lot of this, so I can run through these, but the older designs had the Swanson hinge, and the newer designs are surface replacements, and I had the opportunity to go to the CapFlex workshop on yesterday, and it was very interesting to see this implant, and it looks good, and I like the idea of it, and a lot of the techniques are similar to what I'm going to show you today. The one that I'm going to talk about came out of the Mayo Clinic many years ago, and it's made of chrome cobalt polyethylene, and the big difference between the CapFlex, it's got a stem going down the proximal phalanx and the middle phalanx. So just like a little knee replacement, it really helps you line up the implant well, and as long as you get the stem in the centre, your alignment's, I think, a little bit easier than the other surface replacements. It's not available here in India, I understand, but there's several companies have been marketing it, and it does seem to shift from one company to the other, but currently it is available again in Australia. We had a few years where we couldn't get it. I did a paper a few years ago, and a lot of the pictures in the talk, I'd like to thank Matt Lawson-Smith, who comes from Perth now. He was my fellow at the time. And we did a review of 48 PIP joint replacements that I did over a 10-year period. Majority were women, 9 men. Many of them had multiple joint replacements. So as the previous speaker, I often do 2 joints, 3 joints sometimes. Our results were good. Overall, there was an improvement in the arc of movement, which was definite, and there was a significant from 55 to 81 average. But an important point which was mentioned before is that if patients have a stiff finger, they're not going to get an increased range of motion. So in the normal arthritic finger, we do see it, but not in the stiff and often painless finger. I don't offer that to patients. The DASH scores were good, and again, they had a low DASH score. The problems that we had, and I'd like to highlight this in my technical talk, is hyperextension is a real problem. And if they hyperextend, they don't like it. and they lock into a hyperextended position, so we're working hard to try and prevent that. Stiffness, as I mentioned, if they're stiff to start with, they're not going to get a good range of motion. And in the initial part of the study, I had problems with suture irritation from my non-absorbable stitch for the central slip. I've since worked on burying that, and there doesn't seem to be a problem now. So hopefully in this last few minutes, we're going to go through the surgical technique. I used to template with x-rays. It's pretty hard with digital x-rays, but I still try and get an idea of the size. I always have the plastic set available so that if I'm not happy with my surface replacement, I can just switch straight across and use the previous Swanson type of implant. And I always like to have more than one implant of each size for each finger I'm doing, expecting the nurse to drop it on the floor, so that way I have another box that I can open. You don't want to be there when you've got everything ready to go and you don't have an implant. I use a tourniquet. I'm interested to try the previous one's walnut. I use intravenous antibiotics. I like the bag technique to get plenty of antiseptic on the skin. Again, dorsal V-shaped approach. Nice thick flaps, so you're not going to have a problem with undermining of the skin. And I go straight through the middle of the extensor tendon like we talked about. I don't use those other techniques, but I have seen the volar approach and I'm interested in trying that. And I just take the central slip off the middle phalanx, and I'm going to try and repair it to a certain extent later on. Then we get a good look at the PIP joint, and what's important is a surface replacement, so you need to have your collateral ligaments. So you just need to recess the collateral ligaments a little so that you can get a good look at the proximal phalanx. Often they're quite stiff, and you want to flex the finger down to 90 degrees. I like a nice light saw. One of the things I like about this is that there's no jigs. It's all freehand, and you just have to get a perpendicular cut through the proximal phalanx, taking off the condyles just distal to the collateral ligaments. And the second cut is beveled at 45 degrees. And if you're not quite sure about that, you can just look at the trial, and that'll show what it's going to look like. And so it's freehand cut, no jigs, take off the bottom of the proximal phalanx condyles. I do the proximal phalanx first. It's often larger, and this type of implant you can't mix and match. Your large size has got to go with a large. So I start on the proximal, but I don't go too far in getting it too large, knowing the middle phalanx may be the rate limiting size. We mentioned about the centre of the canals in the dorsal third. It's a bowed bone, and if you're worried at all, take an x-ray, put the awl up the centre of the bone in the AP and lateral, and everything else will follow. You ream sequentially until you get a good fit, trial the fit, check the cuts, and you can often get a good idea whether your bevel's right, and I can show you that in a second. And if you're not happy with the cuts, you can adjust it now. Then we move on to the middle phalanx, and I pull the joint out. Like in the cap flex, there's a spacer to try and give you an idea, but here you distract the joint, and you get a feel for how much bone you need to take off. I do a transverse osteotomy there, just enough to get the implant in, and I use a burr to open up the canal a little bit, and again ream it up, and the middle phalanx is going to be the one that's going to determine the size of the implant. So once you're happy, there's my trial in place. I'm pretty happy. I took this x-ray because the cuts are perfect. I wasn't going to show you a bad one. And you check that the finger moves well, 0 to 90. You don't want it to be sloppy. You don't want it to hyperextend. Now I put in a couple of drill holes to reattach the central slip. Put it in now because you're going to cement, and you can't do it later on. So once you've got, I use what I like to call generation 1 cementing technique. The hip surgeons are up to about generation 18, but my mixture is nice and loose. Put it in a 5mm syringe, nice wide bore Gelco needle, insert the cement, push the implants in, and you put the finger in extension, and that normally compresses it well. Get rid of any excess cement while it's soft. And then this is an important point. You're going to put the central slip back, but not to where it came from. But you can see that the area that the central slip was attached to is now replaced by the implant. So you're putting a drill hole and you're just loosely opposing the central slip, and that just stops the extensor tendon drifting apart, and then you're just doing a longitudinal repair in the extensor apparatus, and I make sure that I bury the knot so that it's not sitting proud. Get it dry, close it, make sure that they're resting in a comfortable position, and then with your post-op rehab, you're trying to not let them go out into full extension. I like them to sit in about 10, even 20 degrees of flexion, and they can go for as much flexion as possible, and they're getting back to most things by 6 weeks. So pre-op planning is good. Make sure you get in the centre of the bone. I tell the patients they can expect good pain relief and good function, but if they start with stiffness, don't expect to an increased range of motion. Thanks very much.
So now I'll invite questions from the delegates. Yeah.
Thank you very much. My name is Dr. Babu. Which antibiotic you use for your thing, please?
We use Kefsol intravenously.
A single shot.
No, I give them a pre-op dose and 2 more doses. They often stay in hospital overnight.
Thanks.
Dr. Tahir.
Hello. What has been the average age of the patients actually in which you have applied this plan?
Elderly, I think the average age in my study was about 60, and we had one patient who was a post-traumatic that I did, and he was only 30. And so in that, because the implant does have a rough surface that can get bone growth into it, I did that uncemented. It's the only one in my study, and the only one I've ever done, which was uncemented. But the vast majority of these are arthritic old people.
So what is the implant longevity in the patients you're doing in 30s or 40s? What do you expect? How many years this will last?
It's a good question. I don't know. I, touch wood, haven't had to revise these. So we're looking at 15 to 20 years so far. But I think if they get 15 plus, I'd be happy with it. And I do tell the patients that. Fusion's going to last forever. A joint replacement is probably going to wear out at some point. I think these probably last a bit better than the plastic ones. The plastic ones break pretty quickly. Yeah.
Thank you.
Thank you, Dr. Chris. Okay. Now I'll invite from the panel Dr. Ramesh. He'll be talking about first CMC arthroplasty, breaking new ground.
So this is the interval act in a PIP arthroplasty session. I'm the imposter. We're talking about first CMC arthroplasty. No conflict of interest for the purposes of this talk. The vast majority of first CMC osteoarthritis patients do well with non-operative treatment, and it's very few people who end up needing surgery. So the gold standard so far has been trapezium excision or trapeziectomy procedures with or without LRTI. Jervis first described this in 1947 in a Royal Society of Medicine meeting. And if you look at the 2 cases he discussed, he did bilateral trapeziectomies in his first patient, and the second patient was milking cows within a month of operation, and at 9 months was milking 20 cows a day. So clearly he was doing it really well. The downside of trapeziectomy is persistent pinch weakness and recovery timescale. So I warn patients that recovery could take at least 6 months for patients to draw a line under the operation. So the recovery timescales are quite prolonged with trapeziectomy. The benefits of arthroplasty are obvious. So girdle stone versus total hip replacement. Mobility is better, stability is better, pinch strength is supposed to be better, and shortened recovery times and return to work. And the CMC arthroplasty is also thought to correct MCP hyperextension in a better way. So we've been searching for the Holy Grail since the 70s, and the initial implants were from Swanson. They were hemi-arthroplasties. They were the silastic variety and the metal variety. And the de la Cafeniere prosthesis in the 70s was one of the forerunners of this in this quest. And then we have a series of non-cemented implants, including the Motec and the Electra, which are also metal on metal. With the hindsight of the understanding we have of tribology and implants and kinetics and kinematics of the joints, we know why they failed. So the Norwegian Joint Registry report in 2014, which looked at revision as endpoint, noted that although the implants lasted, there was a higher rate of implant failure, but the patients did not have a second operation. And those patients who had an implant failure had poor clinical outcomes, and their conclusion was that despite relatively satisfactory implant survivorship based on revision, current evidence does not support widespread implementation of thumb CMC replacements. But fortunately, we did not give up hope, and we continued to learn from what we had done so far. So the next up were modular implants. This improved the game a lot. So you had the RPE, and these implants, and the one at the bottom is the ivory implant. These were modular implants. There were advances in titanium alloy. There was advances in roughening of the stems, and of course, ultra-high molecular weight polyethylene. So the survivorship seemed to improve, but the dislocation rate was still unacceptably high. There was a glimmer of hope with these implants that if we can somehow address dislocation rates, then we might be on a home run. And that was when people started looking at lessons learned from dual mobility cups for hip replacements, which was the dual mobility cups were first described in the 70s, and they encompass two principles of low friction arthroplasty as espoused by Charnley, and the large head principle as espoused by McKee. So that was, for me, the breaking ground for CMC arthroplasty, and we now have dual mobility TMC implants which offer much promise. There are three, as far as I know. They're the Touch, the Maya, and the Movis, and the dislocation rate so far is reported to be very low, less than 1%. We use the Touch CMC in our unit. You have a variety of options for the cups, the liners, and the necks, and titanium stems. So there is dual coating of titanium hydroxyapatite. You have two varieties of cups. You have the conical cup and you have the spherical cup. For the purposes of this talk, I can't elaborate the pros and cons of each of these cups, but I'm happy to talk to you about it later on. And then with the necks, you have straight and offset necks, as well as different heights of the neck. So it's really important that we select carefully, at least at the beginning. The learning curve for implanting a CMC arthroplasty is supposed to be 30 cases, and this is from the series of surgeons who have implanted a lot of implants. So the key is the trapezium. So if you're not sure if you have enough bone stock in the trapezium, it is definitely worthwhile considering a CT scan. We adopt a policy of dual consultant operating until we've got over the learning curve. So all the cases done in our unit is two consultants operating on the patient. And that seems to be the prevalent process in our region in Oxford and Reading, etc. So you need to do an extensive metacarpal release, then resect the trapezial horns, and then prepare the cup via a guide wire that's inserted along the proper axis. And then you assess the neck length and offset, and then you put the implants in. So cup orientation is key. If the cup is open dorsally, then there is a higher risk of dislocation when the thumb flexes. And Joris has done hundreds of implants, hundreds of CMC joints, if not closer to 1,000. So this is this is a image intensifier picture of the K-wire being inserted prior to implantation. The key here is that the K-wire should be perpendicular to the STT joint, and you ignore the trapezial surface. So that's what the key is. And then once you've got the orientation right, then you drive it into the scaphoid a bit so it doesn't toggle, and then you ream over it. Post-operatively, there is an argument whether you immobilize them straight away or put them in slab for 2 weeks. The proponents of mobilization say you would never immobilize a total hip replacement. Why do you want to immobilize this? Whereas in our department, we immobilize patients for 2 weeks in a POP slab to let the soft tissue settle down and then start moving them. The National Joint Registry in the UK does not include CMC joints yet, but we do have the BSSH hand registry for which it's volunteer. You need to volunteer to include these, and we do put it on the registry, and the hand registry sends patients questionnaires regularly to get outcomes. You can assess radiologically based on the thumb length, subsidence, M1, M2, arch line, the Shenton's line. So the future is scary, but it's also exciting. Depends on whether you're cup half full or half empty. Dual mobility prostheses hold good promise, but not sure if they will retain dual mobility. Management of prosthetic joint infections and periprosthetic fractures will soon follow, and I don't know if you're prepared for this yet. The key for me is reporting outcomes. So we need to be honest and open about reporting outcomes and discuss failures, and that is the foundation for further development in this field. Thank you.
So questions for Dr. Ramesh?
The same question to you, the antibiotic protocol.
Yeah, so we use one shot of teicoplanin and gentamicin at induction, and that's it. Our microbiology department have now asked us to use flucloxacillin and gentamicin because we have something called the NC POD study, which is a study of deaths, perioperative deaths nationally. And one of the biggest causes of death in England, perioperative, is teicoplanin allergy, so it can be quite fatal. The arthroplasty team in our department have not adopted to taking accepting fluclox because it's only 6 hours of half-life. So they have insisted on doing teicoplanin. So for this particular implant, for total joints, when we do in hands, we do teicoplanin and gentamicin, one shot, that's it. For all other cases where we don't use antibiotics at all, for Dupuytren's, trapeziectomies, none of the, if there is no implant, there's no antibiotic.
This is early days and you wouldn't have seen a failure yet. So my concern is that if these fail, then what is the salvage? Given that you've already denuded the metacarpal base, it's a very unstable trapeziectomy that you might have to convert into. So I don't know what the experts think about that, but that's just one of my concerns.
Yeah, so the guys who who are big proponents of CMC arthroplasty say that the metacarpal soft tissue release sort of plasters back onto the metacarpal, so that's not an issue. And they say that the salvage procedure is a trapeziectomy and it's fine. But I've also seen an implant being developed that goes into the scaphoid, so it's a revision implant for a CMC arthroplasty, and I don't even want to go there now.
Yeah.
Just only one remark. It's interesting. So if you do a secondary trapeziectomy with tendon in the position, then the results are the same as you do that before.
That's right.
And in our hospital also, some surgeons, they resect the capsule during this operation for a CMC arthroplasty, and I do a repair, and we can't see any difference. Yeah. That's interesting.
We repair, yeah.
Thank you. Thank you, Dr. Ramesh.
Thank you.
Just to add that in our hospital, we are also doing touch, and we repair the capsule. And we always consent our patients that if we find the trapezium is too thin or there is a breach in the dorsal wall and the cup is not stable, then we will convert it to trapeziectomy then and there rather than bringing the patient back later on. Right. I've got the pleasure to invite Ms. Adeline Clement, who will talk about stylistic implants. Adeline.
Good afternoon, everyone. Thank you to the organizing committee. I have no disclosures except that I'm by no means an expert. I have a large rheumatoid arthritis practice, and I'm a big user of Silastic. And I'm fortunate to follow from my esteemed colleagues because they've covered a lot of what I was going to cover on Silastic replacements. But perhaps we can go over some of the history, and I'll show you some of the available Silastic implants and what's happened over the years. The topic that I've been given is about a new era of Silastic. I don't necessarily think it's new because this has been on the go since the 1960s and certainly heavily used in the UK. We know that small joint arthritis is quite a debilitating condition, particularly for fine dexterity. And Many rheumatoid patients are very stoical, they manage their pain well, but their function's impaired. And similarly, the osteoarthritis patients are debilitated by pain predominantly, whether it's post-traumatic or whether it's degenerative change. Improving their quality of life is the mainstay of treatment. So in the past, surgeons preferred amputation and arthrodesis over replacement, surface replacement, or silastic implants. Post-World War II, the Vitellium cup was developed, and lots of research has been poured into developing appropriate implants for small joint arthropathy. And then in 1966, this gentleman came along, Alfred Swanson, who developed the Swanson silastic implant, which was the initial gold standard implant. There's been a few since then, and we'll talk a little bit about them. So the original Swanson silastic implant is a constrained silicone implant, so it's a constrained interposition implant. It's a piston within a bone, so the implant pistons within the intramedullary canal. Essentially, it's quite, I sometimes tell patients, it's quite a glorified spacer that's hinged. Just like my colleagues have mentioned, they don't get a full good range of movement of arc again, but pain relief is usually quite predictable. In 1985, metal grommets were introduced to stop bone erosion, which is one of the complications of putting in these implants. And over the year, the single hinge has developed a little bit, but there's been no huge major change that has rocked the world of silastic implants. It still remains the benchmark and gold standard for which most things are compared in the world of small joint arthroplasty. So you've got short-term goals, long-term goals. Ultimately, you want to improve their pain, you want to improve their range of movement, and ultimately improve their function. Silicone itself has desirable properties, so it's heat stable, it's biocompatible, it's durable, it has flexibility, and it can withstand sterilization in most units. The Swanson's implant is a dorsal hinged implant. It creates encapsulation, as my colleague Mr. Sen has said, and it creates a stable, pain-free joint. The motion arc, however, is not hugely improved. There are other silastic implants on the market, the Avanta, the NewFlex, the CariFlex, and these implants have both a dorsal and a volar hinge. So the motion arc is better because there's no volar impingement of the implant. So just a few pictures to show you what they look like. So the top one's a Swanson's dorsal hinge. The Avanta and the NewFlex are hinged on both sides, okay? So I looked over the literature just kind of give you an idea about what the long-term outcomes are. Majority of patients, almost 3/4 in most studies, basically showed improvement in their pain. About 50% get a range of movement of more than 40 degrees of flexion. But when you perform a Swanson's or any form of silastic implant for deformity correction, then the results have not been great. So if you're using it to correct a boutonnieres or a Swanson or swan neck with PIP joint arthritis, then you don't get a really good outcome. The 8 to 10 year survivorship is about 80 to 90%, so pretty good, but it can fracture, and that can be a fracture rate of up to 50%. There's a small sample study for the NewFlex and Integra for osteoarthritis, but they both quote high patient satisfaction. These are the both-sided hinged, and they get good post-op recovery results. Again, small sample study for the rheumatoid arthritis patients in Swanson's, but the PROMs and functional improvements are pretty good, and patients are generally quite satisfied. So complications, the things that tend to happen are hinge failure, implant fracture, dislocation, erosions. If you have loss of soft tissue structures, loss of stability, for example, patients who've had multiple revisions and they have severe deformity, then it's a kind of gray area of whether you should do a silastic implant or not. Mainly because you've got erosion already, the bone stock's not very good, and often the bone's osteoporotic. If you have infection, significant fixed flexion contractures of more than 50 degrees, then the recommendation is that you shouldn't use a silastic implant. Then there's the big debate of the index finger. So some colleagues across the globe would consider it negligent to put in a silastic implant into an index finger because of the forces that go through an index finger, especially when you pinch. But this is a debate. So at the end of the day, I think it depends on your interaction with the patient, what you're telling them, and what they can expect in the long term. But the index finger is the most unstable in terms of post and pinch, so you'd have to address this area with caution. Also be cautious of the painless stiff joint and where there's bone loss. So I'm not going to go over the approaches, I tend to use a dorsal approach. I have done volar approaches, but the flexor tendon in the way always makes me nervous, especially if I've got a registrar hanging on the neurovascular structures and the flexor tendons, so I stick to a dorsal approach. I do a central split. I put in a dorsal intraosseous hole, and I use a non-absorbable suture to reattach the central slip down into its new position, just as Mr. Roberts has said. They then put them into plaster cast for 2 weeks, mainly to rest the soft tissues. For majority of my patients, some of them I'll only use plaster casting for about 5 to 7 days before I put them into a dynamic outrigger splint. And I say this with caution because the North of Scotland patients are quite a unique bunch. They're a law unto themselves, and they'll get up to all sorts of mischief. So I decide based on my interaction with the patient how long I'm going to immobilize them for. So I don't have a strict rule about this. I use a combination between resting splint and a dynamic outrigger splint with my hand therapist, and they get good, reliable outcomes. So I'm going to go through a few case studies, some showing complications, just to make this a bit more interesting and perhaps interactive in the question section. So this is a rheumatoid patient with index finger MCP joint changes. You can see some erosions. There's a little bit of bone loss already. And they went on to have this is quite a few years later, they've had their wrist fused, and they've had a MCP joint replacement put in, but you can see the erosion starting to happen on the metacarpal end and the proximal phalanx end. So you can go on to use a grommet if you're worried about bone erosions in the long term. And this is an example of a grommet in place. So that is meant to stop or reduce the likelihood of bone erosions after putting in a silastic implant. As you can see, my rheumatoid patients are quite advanced rheumatoid. They've got quite significant deformity. This is a patient who's had 3 MCP joints replaced. Now, I'm reasonably sure I've gone on to fuse their middle finger and index finger because of the severity of the contracture at the PIP joints rather than replace them since this images was taken. This is an image that you've already seen Mr. Sen show. This is a PIP Swanson's in a PIP joint, and you can see where the hinge is hinging to allow the flexion of the digit. Again, more advanced rheumatoid, wrist fusion in the past, gone on to have several of the MCP joints replaced, but you can see several of the complications that have happened. If you look at the index finger and the middle finger, they don't look quite right because the implants have either dislocated or fractured. The ring finger metacarpal has fractured over the years. Now this patient is awaiting a revision. This was put in almost a decade ago, and I'm due to revise them. And I must admit, I'm not entirely sure what I'm going to do with the ring finger as yet, but I suspect all these implants have dislocated or fractured. So it's been in for about 10 years. I won't cover the biomechanics. I just want to say, so silastic implants is established place of practice with PIP and MCP joint replacement. I think understanding the biomechanics is quite important to know where your center of rotation is for putting them in. It's not so much a new era as an ongoing use of the implant. Thank you.
Thank you very much for putting up those beautiful pictures of Scottish Highland. Any questions?
Ma'am, when do you replace the implants if it is fractured? Immediately, or you go for an orthodesis?
So for the PIP joint, it depends. So if they've been in for a long time, it's why they fractured. If they fractured quite recently or have dislocated quite recently, then again, it's a discussion with the patient as to how they want to proceed. But if it's something that's been in for a long time, for 10 years or more, and the lifespan of the implants just occurred, and they still have reasonable bone stock, I do just replace them. I just change them. I revise them with a like-for-like Swanson's, and they seem to still do well. This is in the rheumatoid group, not the osteoarthritis group. So in the osteoarthritis group, if over time the implant fractures and displaces, I still have that discussion. If they want to try another Swanson's, they can. Otherwise, I go straight for fusion.
Thank you.
You're welcome.
Any other questions? Okay, we'll move on. So the next speaker, I would like to invite Dr. Schindel from Switzerland. Am I right? Yes. Navigating complications, managing PIP joint arthroplasty challenges.
Dear chairs, dear colleague, thank you very much. So I come from Switzerland. Some pictures. These are my disclosures. You see that here. This is a hospital, an orthopedic hospital, where we perform about 70 to 80 PIP arthroplasties per year. And not only one, so we use surface replacement, silicone one, and we do only a few orthodesis. Are there challenges in PIP arthroplasty? Yes, there are. So you see there are soft tissue problems, also implant problems, and I will go through these topics in the next minutes. The solution for everything would be the arthrodesis, but usually in Switzerland, the patients don't want to have an arthrodesis on their joints, but first try that to do it, keep him mobile. So this was at the FESH Congress this year in Rotterdam. We had a battle between arthrodesis, where Germany was, and PIP arthroplasty for Switzerland, and here Switzerland wins 8-2, so also in Europe. Usually the surgeons want to try to do an arthroplasty and not first to do the fusion. If we go to the big joints, and I think this is very important because we know there have data about more than 50 years. In hip and knee arthroplasty, usually the revision rate over the 10 years is 12%, so it's not zero. If we do on a joint an arthroplasty, then we have to know that there should come some complications. And usually in the big joints, it's a complication of the implant, and at the fingers, usually it's a soft tissue problem. There's an analysis of Kevin Chung, published 2018, and he's seen that with silicone implants, usually at the PIP joint, we have a complication rate between 6 and 11% for the surface replacement, and this was the first generation, more the pyrocarbon implants between 18 and 37. It changes also depending to the approach. In our registry, we did an analysis. We published that also 2021 with 703 implants. You can see the soft tissue reoperation rate was much higher with the surface replacement. The implant reoperation rate was about the same with silicone and surface replacement, but axis deviation was much higher with silicone implant. So I think this is very important, managing the soft tissue in each operation you do. Look that you look for the pretendinous tissue. Don't open it too much. Usually, and that's why we changed that to the other speakers. We don't do a refixation of the extensor tendon to the central insertion, because otherwise we perform a high tension on the tendon, and then that's why we create this one neck deformity. The volar approach is better. We use that for the silastic implants. The dorsal we use for the surface replacement. So if you have a swan neck deformity, and this is the first complication, then we usually treat it only if we have functional limitations. First, we start to try with a swan neck ring, or if you have a severe, like here on the right radiograph, we do FDS hemitenodesis. You see that here. We take a slim of the superficial flexor tendon, and we roll it around the A2, C1 pulley, and we fix it on the A3 pulley with some slight flexion of the finger. If we have instability, usually we'll use the surface replacement because they have better stability, and that's why we use the surface replacement at the index finger, and at the ring and little finger we also use silicone. But we also have to know if you use silicone in case of a pre-op angulation, then it will come back. You see that here on the middle and on the ring finger, severe angulation of the finger. This patient is pain-free, but yeah, with the aesthetic situation, not very comfortable. Then here you see that here, pre-op angulation on the small finger. In this construction worker is a Bentley Mechanics, and this is 17 years after a handball trauma. See that here also reconstructed the radial collateral ligament, and this is the function. Now it's more than 5 years back. I think very important is managing the soft tissue, and the PIP arthroplasty is a soft tissue procedure. That's why we don't do a refixation for the dorsal approach for the extensor tendon. That's why we do an immobilization for about 2 weeks in slight flexion up to 10 degrees. And in case we have a pre-op angulation of the finger, then usually we use an immobilization up to 3 weeks, and we do a short arc motion program for the patient to protect the extensor tendon. Managing implant complications, so loosening of the implant usually is not a problem in the PIP joint, because elastic implants, we know they are loose. We have the pistoning, and they are inside the bone, and that's why that's not a problem. Also today, not in the surface replacement. We know that with pyrocarbon, we only had an apposition, and there sometimes we have loose bone, but also with these small packs, usually it's not a problem, and it is also published. Then fracture of the implant, we know that in silicon, I think after 10 years, usually 90% of the silastic implants will be fractured, but only 40% will be with pain and with increasing risk of angulation. And you can see that here. Usually if we have that and the patient is not satisfied and you look to the index finger, then you have to solve such a problem and the severe angulation with an arthrodesis, as we hadn't done that here. But on the right finger, because of the huge holes in the medullary canal, we used a surface replacement, as you see that here, with cement, and the patient is still pain-free. Dislocation of the implant, also you see that here. This is a patient 10 years after silastic implantation of the PIP joint in the ring finger. There you have to explant it. Also, you can do that in ring finger arthrodesis, but balancing the soft tissue is very important. And there we changed also to a surface replacement to get a little bit more tension on the finger and to get it also longer. Also here you have to do, you have to look for the radial collateral ligament. Also, if you lose surface replacement, then you can have a dislocation of the implant. And usually in this case, we use the volar approach. You see that here for opening up, and sometimes you have also to balance in the soft tissue, and you have to change the polyethylene to get the finger a little bit more stability. Yes, you see that here. Then persistent pain and stiffness. This is also very often in silastic and in surface replacement. So if you have a stiff joint in slight flexion and the patient has pain, then you can only change to silicone if you don't have too much open up the medullary canal. So this is our decision tree. You see that on the ground. You see that we do arthrodesis, we do surface replacement, we do silicone implants. We look a little bit to the bone stock, then we look to the finger raise. On the radial side, more surface replacement. On the ulnar side, more silastic. And in young patients, usually we know that they have to stay with the implant very long. We use the surface replacement. Thank you very much for your attention.
Thank you very much. Do you have any questions? It has to be quick because we're running out of time.
Can I just make a comment? It was a very good X-ray you showed. I think third last X-ray, a slide where you had an implant in one of the fingers and the adjacent finger had a DIP fusion screw going through it, one of the radiographs. I think that's a good example of a reason why you should probably consider a surface replacement, because you don't have two stems meeting each other in the middle phalanx and creating either a stress razor or even not getting you enough length of either the stem or the screw.
Yes, I think to correct the angulation, it's very important that you also correct the DIP joint, and we have that published, and that the difference of the results of PIP arthroplasty with DIP fusion and not are the same.
Great. If there are no more questions, we will call an end to this session. Thank you very much to the speakers and all of you to have taken an active part. Thank you.
Thank you, panelists and speakers, for that engaging and thought-provoking session. Your active participation and insightful feedback were truly inspiring. Now let's get ready for inspiring ideas and cutting-edge research as the best paper presentation is about to begin. I now cordially invite Dr. Saumen Das De, Dr. Samuel C. Raj Palapati, and Dr. Alphonsus Chung to lead this session.
Good evening, welcome to all of you for this best paper session. Without much ado, we'll get going. The first paper is by Dr. Arshia, Lieutenant Colonel Arshia, on revolutionizing rehabilitation, a randomized control trial for post-operative flexor tendon repair utilizing smartphone application. Yeah, Dr. Arshia.
Good afternoon, everyone. This article is on a randomized control trial for post-operative rehabilitation in a flexor tendon injuries utilizing a smartphone application, which we have done at AIIMS, New Delhi. So, in being a tertiary care center, we receive a lot of patients outside Delhi, that is from nearby states, and 50 to 60% of our OPD loads are laborers working in various factories, construction workers, farmers who are managing their daily life with machineries and operating on sharp tools. So our flexor tendon injuries, majority are at the wrist level, that is flexor zone 5 is commonly involved, and we have seen that the ineffective rehabilitation has led to 30 to 40% complication rate, which implies the role of effective post-operative rehabilitation. And during COVID pandemic, we have used virtual exercises and telemedicine, which led to the decreased infrequent visits of these patients and also effective use of skilled manpower. So we thought of devising a smartphone application for these patients with customized physiotherapy, because we know these are manual laborers, they have to go back to their work with a good functioning hand at the earliest. So our prime objective was to evaluate the non-inferiority of using mobile app for remote rehabilitation among post-operative zone 4-5 flexor tendon repair in terms of dash score, and our secondary objective was same, which we calculated in terms of TAM score. So with the help of AIIMS research funding, in our phase 1 we devised a smartphone app by name HIRE, that is Hand Injury Repair and Rehabilitation. It adds two interfaces, provider and a patient interface, and a customized physiotherapy exercise. This is a video of our app. We have a unique identification number through which an email and password is generated depending on the patient. And the patient gets the username and a password with a link of the app. He downloads it. Like an example in this, Rahul patient. And where we have a calling facility, and he, depending on the day of surgery, his exercise has started. He does it and hits the icon as done. So we can monitor the progress, and he can chat with the provider, that is the doctor. And at the provider interface, we can see the patient progress of exercises, and we can chat with the patient, and we can even change the exercises depending on their adherence level and the improvement. So this is our app display, where we have a calling facility as well as they can chat with the patient and a brief introduction about the tendon injury, the joints involved, and the splint care. And patient does the exercises, and if they have any doubts, they can send images or they can type. So this is a 2-arm parallel open label 1:1 randomized control trial with block randomization, and the numbers were placed in individual opaque envelopes, and we followed a modified Durance rehabilitation protocol. Acute zone 4 and 5 tendon injuries were included, and it was done at AIIMS New Delhi Plastic and Reconstructive Surgery Department, and it's a 2-year research, and the sample size was 60 patients after calculation. The inclusion criteria was an adult more than 18 years with acute zone 4-5 tendon injury having a smartphone facility, and exclusion criteria were patients who were non-compliant with the smartphone use or not following our commands and who developed immediate post-op complication in 2 weeks. So this is a brief layout of our study, which shows that the smartphone application, they have a hourly exercise pop-up reminders with customized videos, and we can monitor their adherence to the therapy. And at day 2 they are discharged. At 2 weeks they have called for suture removal, and next follow-up will be at 3 months. When compared to conventional group, they come every twice weekly till 8 weeks, then every fortnightly for 12 weeks. Till now, we have enrolled 37 patients, and they've randomized into 19 patients of smartphone and 18 into convention, of which in smartphone group, 11 patients have completed their 3 months of post-surgery duration. 1 patient is lost to follow-up, and total analyzed were 10. The same patients, almost 10 were analyzed in the conventional group, with 1 patient who developed a post-op complications. In our results, we found that 20 to 30 years was the average age group, and this implies that these patients' financial loss with frequent physiotherapy visits is important. So our aim was to give them a functional hand at the earliest. And the mode of injury was glass cut common, followed by machine cut. Associated injuries were there, nerve injuries in 18 and arterial 4.5, both in 68%. In smartphone group, the median was dash score was 13.3, and in conventional 22.6, and we know that lower dash is better outcome. And in time score, the smartphone group fared well, with many outliers in the conventional group. So in review of literature, they've shown that adherence is better in smartphone group. And in our study, we saw that lower median dash and higher time score was in a smartphone group, and conventional group have a wider interquartile range. Limitation of study is smaller size and shorter follow-up which will achieve. To conclude, integration of smartphone application into rehabilitation program can enhance patient engagement, thereby we can improve our functional outcome and ensure a more reliable post-op recovery in tendon injuries. Thank you.
Yeah, we have time for any questions if anybody asks.
Hello, doctor. You said all your patients are farmers and then workers, labor workers.
So majority of our load are farmers and construction workers or
I'll finish my question.
Yes.
But you said the smartphone. How did you educate them?
Sir, that was a surprise. We have done a study in AIIMS, which we have seen that many of our patients have a smartphone. After that, we continued with our study.
It's very impressive. Thanks.
So.
I have a question. I thought this is a very elegantly done study. You initially projected 60 patients, so now you have studied 37. Is this a planned interim analysis, or is there a plan to continue to the 60?
Sir, my plan is to continue, sir.
Okay, thank you.
Yep. Thank you very much for the study. A couple of questions. First is, did you manage to blind the patients? Second is, how do you decide the sample size? And the third question is, what was the third question? Sample size. Okay, when we answer the first two, I'll try to remember my third question.
Sample size, we are compared with the review of literature of previous studies which we have done, and we have calculated the mean dash score was the main primary outcome of that. Depending on that, each sample size was 24.
How about blinding?
Sir,
blinding. Was it blinded? Not
yes,
blinded?
sir, double blinded. Even the sealed and there was opaque envelopes which was not by the provider.
Final assessment is blinded.
Yes, sir.
Okay. Why do you do zone 4 and 5 versus something else?
Zone 4 and 5, sir, that was common in our studies. So we thought the incidence of the injuries was more common.
Thank you. Thank you very much.
Thank you.
I have an announcement to make. Yeah, thank you. Dr. Chaitanya has said that the Khuda Mudgal Foundation will sponsor the registration fees for all the finalists in the best paper presentation. So thank you very much for that gracious gesture. Also, they will sponsor the prize winner for the quiz that's happening tomorrow. So that's very good, and we appreciate that. Thank you so much.
So, good evening, everyone. I want to start my presentation with a small case example of patient by name Tony. He is a 30-year-old gentleman. He is a known case of left-sided spastic hemiplegic cerebral palsy with poor hand functions. Looking at his appearance, Tony is a good-looking, tall, fair gentleman. But the problem is, he is so much concerned about his flexed posture of his left wrist. So since it is a fixed flexion deformity, we decided to fuse his wrist with a plate. After wrist fusion, what happened is, Tony's position has changed. Now he looks better than before. But does this wrist arthrodesis improves the hand function also? So that is what is my study. My aim is to analyze what is the functional outcome after wrist arthrodesis in cerebral palsy. Initially, before my study, I tried to review the literature. From the literature, initially it is said that wrist arthrodesis is a salvage operation. It is done to improve the position of the hand, and it can be done to improve the hygiene of the patients. Then later on it is said that wrist fusion can improve the hand function also. So my study is a retrospective study with a total of 25 patients. We fused 26 wrists since it is bilateral wrist arthrodesis in one patient. The duration of the study is 2011 to 23. My minimum follow-up is 1 year with the maximum follow-up duration of 8 years available. The mean age at the time of operation is 19 years. Most of my patients are hemiplegic type of cerebral palsy. I tried to categorize my patients according to this standard Zancolis classification. What I found out that this is a simplified classification where there is a big gray zone between these type 2B and 3. Most of my patients are come under this gray zone only, where they cannot be categorized in any of this type. According to these guidelines, type 3 is a wrist we should fuse. We also fuse type 3 wrist. My other indications are, if you see the first picture, his all finger extensors are working, but he is having a fixed flexion deformity. This is a stiff wrist. A stiff wrist is an indication of fusion in all the literature also. But we slightly extended our indication in fusing supple wrist also in scenarios where there is only partial digital extensors are working. So if you see in this video, the index finger and the thumb is dropped inside where other ulnar 3 digits are working. In this case scenario also we do wrist fusion. In all the finger flexor, all the wrist flexors are found to be so tight, which needs aggressive fractional lengthening. If only one wrist flexor is working where we cannot do tendon transfer, if FCU is found to be so much spastic and there is no motor control also, in this situation if you try to do tendon transfer or soft tissue release procedures, what happens? They all develop in the deformity which is shown in the last picture. A wrist flexion is a disability where the patient come to us, whereas the extension will be a disaster. So these are the ideal candidates for neutral wrist. Suppose if they present to us with this extension deformity also, the only solution is wrist arthrodesis, provided the age should be more than 14 years. Our method is we address all the deformities as a single even multi-level surgery. Coming to the wrist, all the wrist fusion will be combined with proximal row carpectomy. This PRC will address the tightness of the long finger flexors also. We address all the deformities, soft tissue release procedures in the first stage. Now we ask the patient to use the hand, they undergo physiotherapy, everything. After 6 months, we specifically assess for thumb abduction, thumb extension and the extension of the other fingers. Now whatever deficit is there, these deficits will be addressed by doing a tendon transfer from the flexor aspect of the wrist, which is available as donors for us now. And we did wrist arthrodesis combined with tendon transfer in 13 patients. The patients undergone wrist arthrodesis plus PRC is only 3. Patient undergone wrist arthrodesis plus soft tissue release is 5. 4 patients are waiting for stage 2. I tried to analyze my result with the help of the Likert scale, parental satisfaction. I asked the parents only, so when you will get satisfied after your surgery? According to the parents, if my child is able to do some new activities after surgery, we are satisfied. So I put forward the same question, is your child is able to perform any new activities now, which is not possible before operation? So they tell their satisfaction score depends upon the activity they do. Then I score their satisfaction score according to the Likert scale. My second tool to analyze the result is House scale. After wrist arthrodesis, what happened is they lose all the movements around the wrist, and there is an implant inside the forearm and giving multiple scars around the forearm in these good looking adolescent girls. I found out that the parental satisfaction is 3.3 out of 5. All of my patients are able to do some new activities which is not possible in their life. This fellow is able to ride bicycle and go to school. He is able to participate in sports activities. He is able to open a flask and drink water. She is able to sweep her home. He is able to brush his teeth. She is able to drink water. These are small activities, but these are the activities which are going to improve their quality of life, which is much important in these CP children. My study is functional outcome of wrist fusion, but I feel the suitable title for my topic should be parental satisfaction after wrist arthrodesis in cerebral palsy. My preoperative House scale is 2.3, which is significantly improved to 4.5, which is statistically proven also. Parental satisfaction is assessed separately for position, which is found to be 4.4 out of 5. Coming back to this Tony story, what Tony is able to do now, which is not possible before surgery, is he is able to do all gym activities now. Wrist arthrodesis improves the appearance in every patient. Wrist arthrodesis alone will improve the grip of the hand. Whereas if we do tendon transfer to augment the thumb extension, abduction, digital extension, they all are able to open out the finger better. A prehensile hand will be the functional hand. So the function will dramatically improve when you restore the finger extension and hand opening out by doing a tendon transfer. Thank you.
Thank you. Are there any questions for Dr. Mukil?
Hi, nice presentation. I assume you're doing the EPL rerouting, then coming back for fusion in the second stage, right?
Yes, sir. Whenever a tendon transfer or a tendon procedure needed for the thumb, we will do it in the first stage. But whenever a tendon transfer procedure needed for the extensor digitorum communis, we do it in the second stage because the line of tendon transfer exactly come over the plate. It will cause adhesion and it may hamper our results. So we do it in the second stage.
So when you do the proximal toe carpectomy in the second stage and put a plate, don't you think you're disturbing the tension and the EPL rerouting?
So proximal toe carpectomy will be done in the first stage itself.
No, you're doing the plating in the second stage, right?
No, sir. Wrist arthrodesis combined with PRC.
The EPL rerouting is first stage.
EPL rerouting will be done in the first stage.
Won't that be disturbed when you do a PRC and a plate dorsally, the EPL?
No, sir. It is the rerouting doesn't disturb our results, sir. We do only tendon transfer to EDC at second stage, sir.
Will you do bilateral wrist fusion for the diplegic? If there is severe deformity like this,
yes,
both
sir.
the hand. You will prefer both the wrist fusion?
Yeah, we did in one patient, sir. We did bilateral wrist arthrodesis on one patient.
So which position?
Both the wrist we did
extension?
in no, sir. Neutral position only. Sir.
Both neutral.
Neutral.
Okay. No flexion in one wrist and one in extension.
No, sir. No. Only one patient we did diplegic cerebral palsy. We did both the wrist in neutral position.
Okay, thank you.
Dr. Mukil, I have a question for you. Most of your patients are quite old. They are teenagers, it looks like. Why did you go for parental satisfaction and not the patient satisfaction?
So parents are the one, they are watching their kids right from the childhood. They are seeing them from the childhood. They are all spastic children. Some patients they are able to tell about their activity, everything, their own assessment they have. But most of these children, IQ wise, little they are not that much able to tell what they are able to do, what they are not able to do. So I feel the parental satisfaction will be a better assessment.
Okay. Any more questions for this presentation? One more. Sorry, two more.
Hello, sir. And as we all know that in both elbow stiffness and we do that on right hand bilateral stiffness of elbow, we do that right elbow in flexion so that the patient can heat and the left elbow in extension so that patient can use it for personal hygiene. In that case, that both wrist have like stiffness, can we use the same principle here also, or is there any comments on that, sir?
So actually, that one patient is around some 16 years old. Both of his hands are just his supporting hand, his diplegic height of cerebral palsy, just to mobilize himself, take care of himself, that's all. His washing activities and all, his parents only taking care of him. So we thought that both of his wrist will only work if we do fuse the wrist. And he doesn't have any finger opening out also. So we feel that we have to fuse the wrist, give some opening out of finger so that he can hold the rail, support himself, push the wheelchair, like that.
Okay, we'll have one more question, then we'll...
What is the youngest age in your series?
So in my series, the youngest age is 13 years, sir.
Okay. 13, were there any practical difficulties in fusion in terms of cartilage, and did you have to use a bone graft?
Sir, what we feel is if they grow, all this tendon transfer will act as on a static tendon transfer only. So they should not develop the opposite deformity. So we preferably do when the skeleton is matured.
Why not a PRC and a tendon transfer rather than going for a wrist fusion? Because 13 is too early for a wrist fusion.
So only one or two
PRC and a tendon transfer can give equally or even better results and keep some mobility on with splinting, compared to your wrist fusion. Thank you.
Maybe that will be a control group for the future study.
Okay.
Thank you.
Thank you.
So next up, we have Dr. Anand Krishna, who's going to talk about hose technique in scapholunate instability.
Respected dignitaries and my dear friends, a very good evening.
So I'm here presenting a topic, host technique, a boon to patients with scapholonate instability, a case series. So scapholonate dissociation is the most common carpal instability, and the scapholonate ligament is the primary stabilizer of the scapholonate joint, and it consists of three components. First one is dorsal portion, which is the thickest and strongest portion, and it prevents the translation. And the volar portion is the second one, which prevents rotation, and third one is proximal portion. So any disruption leads to lunate extension whenever the scaphoid flexes. So finally creating into a disc deformity. So our aim is to restore the SL joint stability and prevent the progression into arthritis. So the various treatment options available are capsulodesis, tenodesis, bone retinaculum bone reconstruction, reduction and association of the scaphoid and lunate, and ligament reconstructions. The most of the methods provide only dorsal and uniplanar reconstruction. So whereas it is logical and more ideal to restore both the dorsal and volar components. So our aims and objectives are to evaluate the outcome of SL ligament reconstruction for SL instability using PC Host method. So arthroscopic evaluation and reconstruction of dorsal and volar SL ligament simultaneously using a free tendon graft in a box-like structure without violating the blood supply to the scaphoid and the soft tissue envelope, which is the capsule. So our materials and methods. So from June 22 to July 23, we did a case series on 10 patients with scapholonate instability. All of our patients were having dorsal wrist pain occurring especially at the extremes of motion and a sense of instability and a painful clicking. And Watson's test was invariably positive in all patients. And disc deformity was present in 3 patients. 1 patient had SLAC 1 stage wrist changes, and 7 patients were having Gisler's grade 3 instability, and 3 were having Gisler's grade 4 instability. And our pre-op parameters, we calculated the mean values. So PRW score was 64 out of 100, active extension was 52 degree, flexion was 45 degree, radial deviation was 15.5 degree, ulnar deviation was 25 degree, and mean power grip strength was 27 kg, and average SL angle was 77.8 degrees. SL interval was 4.9 mm. And in supine position, with the arm suspended in a wrist action tower, we did arthroscopic evaluation. So in this we can see the gaping of the SL joint. So this was Gisler's grade 3, and we did a limited dorsal and volar incision to expose SL interval without violating the capsule, and we passed cavers through the scaphoid and lunate, showing the C-arm images. And we did bone tunnels were drilled, 2.4 mm bone tunnels were drilled on scaphoid and lunate, and a palmaris longus tendon graft was harvested in 9 out of 10 patients. 1 patient was having absent palmaris longus, hence we harvested plantaris tendon, and the graft was delivered through the wrist capsule and through the bone tunnels to reduce the 2 bones in a box-like fashion. You can see in the picture. And we did arthroscopic confirmation in this video, showing whenever the graft is pulled, we can see the reduction of the SL joint in the screen. And the joint diastasis was reduced. Finally, the graft was knotted and sutured on the dorsal surface extracapsularly in a shoelancing manner. So finally, scaphocapitate and scapholunate joint were transfused using K wires to protect the reconstruction for 6 weeks in a plaster. The pins and plaster were removed after 6 weeks and followed by gradual wrist arm exercises. Gradual strengthening was started after 12 weeks. So the results, the average follow-up was 15 months. Out of 10 patients, 8 patients were able to return to the pre-injury job level, and 2 patients had some restriction at work. 3 had some wrist pain on maximum exertion, but none of them had any wrist pain at rest. And none of the patients had any tenderness at the SL interval. The Watson test was negative in all patients. The mean grip strength was 36 kg, which was the 133% of the pre-op status and 86% of the contralateral side. Radiographically, SL interval was 2.8, whereas pre-op was 4.9 mm. There was no further progression of degenerative changes in the patient with SLAC stage 1. There was no infection or any neurovascular complication in the series. For subjective assessment, we used PRW scoring. So follow-up, we calculated grip strength, range of motion assessment were done, pre-op and post-op x-rays were compared, and PRW scoring was used for the subjective assessment. And we tabulated all the pre-op and post-op values, including PRW score, mean grip strength, SL gaping, and SL angle. Finally, we charted it. So PRW scoring, it was 64 pre-operatively, which reduced into 14 post-operatively, Mean grip strength was 27 kg and postoperatively 36 kg. SL interval was 4.9 whereas postoperatively 2.8. SL angle was 77.8 reduced into 58.9. Range of motion, flexion range increased from 45 degree to 53 degree, extension 52 degree to 59.2 degrees, radial deviation 16.5 to 19 degrees, ulnar deviation 25 degrees to 31.7 degrees. The improvement, there was 18% of improvement in flexion, 14% improvement in extension, 15% improvement in the radial deviation and 27% improvement in the ulnar deviation. So conclusion, so this minimally invasive technique is a logical and highly effective technique of SL ligament reconstruction. It restores complete stability of the SL joint as well as prevent the progression into arthritis. The risk of ischemic necrosis of the carpal bone is minimized by preservation of the scaffold blood supply, the small size of the bone tunnels and the inclusion of the capsule at the reconstruction site. So hence we can say it's definitely a boon to patient with scapholonate instability. Thank you.
Thank you very much. Open up to the floor. Any questions for the speaker? If not, I can start the ball rolling. What do you think are some of the advantages of your technique versus that published already in terms of outcome?
Yes, sir. The main mother study was PC host reconstruction. So they have published a similar article, but we used some different scoring also. So we included PRW scoring and some other scoring instead of the mother study. So both studies showing the similar results only. So improvement was much better in our study actually. Yes.
No, thank you. We move on to the next speaker. Dr. Sumya, who speak on determination of the efficacy of medical treatment of neuropathic pain in traumatic brachial plexus injury patients. Thank you.
Good evening, everyone. Today I'll be speaking on determination of the efficacy of medical treatment of neuropathic pain in traumatic brachial plexus injury patients. So, as we know, neuropathic pain after traumatic brachial plexus injury predisposes the patients to emotional distress. But this kind of pain is very difficult to treat as there is frequent relapse and partial response to treatment. Although it is a common complication, but the incidence of neuropathic pain has not yet been well documented in the Indian population. So this prospective hospital-based single center study, it is designed to seek more reliable information on the incidence as well as the characteristics of neuropathic pain. The objectives being to determine the response to pain with step-ladder approach and to estimate the incidence of neuropathic pain in patients with traumatic brachial plexus injury. So the present study is being conducted in the Department of Plastic and Reconstructive Surgery at our institute. The duration of study, it has been done from February 2024 to September 2024. It is a prospective observational study, the sample size being 31. The definite diagnosis of traumatic brachial plexus injury was confirmed with meticulous physical examination, and the diagnosis of avulsion of nerve roots was made using magnetic resonance neurography. Demographics and baseline information was taken into account, such as the sex, age, the affected hand, the nerve roots which are involved, and the pain locations. Neuropathic pain was evaluated using the Lamb's pain scale score before and after medical treatment, which represented the presence or absence of pain. As we can here see, the Lamb's pain scale, which includes the pain questionnaire as well as the sensory testing. So first we took the VAS score before the treatment regimen, then we subjected the patient to tablet pregabalin 150 mg BD, which was given over 4 weeks, and then the VAS score was calculated. When the patients presented with VAS score more than 4, they were considered as non-responders, and amitriptyline 10 mg BD was added along with tablet pregabalin. They were again observed for 4 weeks. Again, if the VAS score was more than 4, they were considered as non-responders, and such patients were subjected to stellate ganglion block. Those patients with VAS score less than 4 were considered as responders, and the same drug was continued for 3 more months. So total number of patients were 31, and the patients who presented with neuropathic pain were 17. Mostly male patients were there, that is 15 out of 17 patients who complained of neuropathic pain. And the most common age group which was involved was of the working age group, that is 26 to 45 years, and right hand was mostly affected. Patients presented to us within 60 to 72 days post-injury, and these were the accompanying injury along with traumatic brachial plexus injury. Location of injury was mainly panplexopathy as all the nerve roots were involved. So 17 patients were started on pregabalin, out of which 7 responded and 10 were non-responders. Then the patients were stepped up to pregabalin along with amitriptyline, out of which only 2 responded and 8 were non-responders. So according to a previous study, 50 to 82.7% of brachial plexus injuries suffer from chronic pain. In our study, the incidence of neuropathic pain is 55%. Allodynia, hypersensitivity, and electric leg discharges are mostly present in the T1 and T2 at the posterior aspect of elbow. In the study by Sheena Derry regarding pregabalin as treatment in neuropathic pain, 30 patients responded with reduction in pain intensity, while in our study, we can see 42% of patients were responders. Out of the non-responders, 20% responded to pregabalin along with amitriptyline, in contrast to 25% response as seen in a previous study. So this study predicts the incidence of neuropathic pain in patients with traumatic brachial plexus injury who have presented to us within 2 months of injury, that is 55%. As 42% of patients have reduced intensity of pain after 1 month of regimen, it might be considered as the first line treatment of neuropathic pain. And the non-responders might be stepped up with addition of amitriptyline. 1 patient was excluded from the study concerning drowsiness, which was affecting the trivial work. Study can be done on a larger scale for a more collated conclusion, and neuromodulation techniques can also be taken into account. Thank you.
Yeah, thank you, Soumya. Any questions, please?
Hi. My question is, usually for most of the patients, we give pregabalin 75 mg and they still complain of drowsiness, heavy-headedness, giving 150 mg, that to a BD dose.
Yes.
And I'm surprised that only 1 patient has complained of drowsiness. And your study had a time period from February to September this year.
Yes, sir.
So now we are in start of October. So how
Yes,
was
sir.
your follow-up on these patients? How soon you are following up?
So the study is still continuing, as we have planned on giving the patients the same treatment for 3 more months, those who are responders. So study is not complete yet. We are continuing with the study.
Yeah, one more question.
So the question is, I think brachial plexus post-neuropathic pain cannot be scored just based on the VAS score because it's more complex. The pain they have is psychological, sleep issues are also there. So VAS score, my comment is, it's not a question, my comment is that the VAS score may not be enough to classify patients as responders and non-responders because the pain is much more complicated than a simple VAS score can, give us, it will not give us a good picture, is just a comment.
Yeah. Next one.
So, how soon do you analyze a patient after starting the medical treatment, whether the patient is a responder or not a responder? Because many times it may take some time for it to respond to. So, what would be the time frame you are looking at?
So it's 4 weeks, 1 month after the treatment has started.
Okay, and there are like more than 50% patients who have not responding to the medical line of management. So what would you do with them? Because it's a very large amount of patients who have not responded.
So we are planning on doing stellate ganglion block. We have not yet started it because the study is still continuing, but we are planning on doing a stellate ganglion block to those patients who are not responding to medical therapy.
Sure.
What is the longest follow-up you had, Soumya?
So of 3 months, 2 patients.
Okay. So you did not have time to find out if the response is coming down with time,
Yes,
isn't
sir.
it?
Yes, sir.
Yeah. Okay. Thank you very much.
Thank you so much.
We'll move on to the next presentation by Dr. Arunava Kumar Bhuyan. He's presenting patterns of presentation of operated hand and upper limb tumors with special emphasis on malignant tumors.
Good afternoon, everyone, chairs, audience. So, patterns of presentation of operated hand and upper limb tumors with special emphasis on malignant tumors. We have had studies which have described the epidemiological profile of these tumors in the international level. Studies by proponents in India have had where malignant tumors of the hand and wrist, the surgical management and the guidelines were outlined, where one such study had 39 malignant tumors with majority being skin tumors. We had a study by Kottu et al. Where 12 samples of synovial sarcoma which were analyzed by IHC and differentiated into its subtypes, where monophasic variant was the most common entity found. Case reports by Vijayan et al. And Aramugam et al. Had described IHC for synovial sarcoma cases. One such study by Mighty et al. Used IHC and helped in diagnosis of 38 cases of soft tissue tumors of the lower limb. This study concluded that immunohistochemistry provides an accurate diagnosis. So there is a limited literature in our subcontinent pertaining to the surgical management of upper limb tumors, especially malignant ones, with emphasis on immunohistochemistry. My aim was to evaluate the usefulness of IHC as a diagnostic tool for upper limb tumors, and to accomplish this, I have studied the demographic data and epidemiological patterns, reviewed the histopathology results, and reviewed the immunohistochemistry reports. So it was a retrospective study conducted between January 2016 to July 2024, where 130 patients of tumors and tumor-like conditions which were operated were included. Statistical analysis was done by logistic regression. So we can see that males were more had more preponderance to develop malignant tumors. However, females in malignant tumors had a lower age of onset. Giant cell tumors were described as a different entity because of their locally aggressive nature, where we encountered 20 cases. The most common location was distal radius with 6 cases, and proximal phalanx of middle and ring finger with 3 cases each. Recurrence was noted as the most common complication. So out of these total 130 patients, we had 27 malignant cases, where Ewing sarcoma was the most common bony malignancy encountered, with 7 cases. Soft tissue sarcoma, including all of its subtypes, amounted to 7 cases as well, followed by chondrosarcoma with 4 cases, and osteosarcoma with 2 cases. When it came to site-wise distribution of malignant tumors, humerus and the soft tissue of the arm contributed to 11 cases, followed by the shoulder girdle and its soft tissue with 6 cases, and followed by the hand and all the digits with 4 cases. Immunohistochemistry analysis was done for 24 cases, where 18 were malignant and 6 were benign. The most commonly positive IHC parameters were CD99, FLI1, which was seen exclusively for Ewing sarcoma, and SMA, which was seen for low and high-grade myopithelioma. Immunohistochemistry studies were, however, at the discretion of the pathologist if HPE was deemed inadequate. So here we have representations of the same. Moving forward, immunohistochemistry led to changes in 7 cases. 6 cases, the subtype was identified, and in 1 case, diagnosis was changed. Logistic regression analysis was done, which showed a statistically significant observation. So here we have a table depicting the histopathological diagnosis and the change when IHC was brought into play. Of these 7 cases, 2 cases underwent change in treatment post-IHC. A case of swelling of the distal end of the radius, which was diagnosed as chondrosarcoma and HPE, turned out to be a case of malignant giant cell tumor on immunohistochemistry. The patient underwent excision and wrist arthrodesis. No chemo or radiotherapy was initiated. Although chondrosarcomas are chemo and radio resistant, high-dose radiotherapy and immunotherapy are being used and studied for the same. Immunohistochemistry helped avoid advanced treatment regimen for this patient. We had another case, a 38-year-old female with shoulder swelling. The pre-op MRI as shown here indicated a tumor, and close biopsy was done. The histopathology reported it as adenocarcinoma. However, immunohistochemistry showed CK7 and GATA3 positivity, which diagnosed a primary malignant adenocarcinoma of the breast. A previously undiagnosed primary adenocarcinoma of breast was identified, and treatment of the primary tumor was initiated. So immunohistochemistry can diagnose a primary from a secondary on the basis of the patterns observed, which can lead to significant change in healthcare approach. So upper limb and hand malignancies can present with wide range of morphological variations. The immunohistochemistry has been predominantly used to differentiate synovial sarcoma and soft tissue tumors. The use of IHC was found to differentiate a tumor into its subtypes, diagnose a tumor which was doubtful on HPE, diagnose a primary from a secondary tumor. However, immunohistochemistry is at the discretion of the pathologist when HPE evaluation was deemed inadequate. IHC depends on selection of antibodies and reaction patterns observed. And the absence of these markers or non-reactivity of markers is a weakness of immunohistochemistry. However, it does have 95% specificity. My study had a higher number of malignant cases compared to the literature. Results showed statistical significance for change in diagnosis and treatment change post-immunohistochemistry. It's a retrospective study, so that is a weakness. So to conclude, of the total 130 cases, 20% were malignant tumors, with males having higher preponderance than females. Age of onset for malignant cases was, however, lower for females at about 26 years when compared to males at about 37 years. Ewing sarcoma was the most common bony malignancy encountered, while synovial sarcoma was the most common soft tissue malignancy encountered. Immunohistochemistry led to a diagnostic change in 7 of 24 cases and treatment change in 2 out of these 7 cases, which were both statistically significant. Immunohistochemistry does offer a low cost and high benefit adjunct to regular histopathological evaluation for upper limb and hand malignant tumors. Thank you.
Thank you. Are there any questions from the floor? Maybe I'll ask one then. It was a nice study. Can I check, did you exclude patients with metastatic disease? I didn't catch that part.
So we did not encounter any patient who was a known case of metastasis. We encountered one case which turned out to be a secondary, and then the primary was diagnosed. So
that's quite curious, because the most common cause of a malignant tumor is a metastatic focus, right? Why do you think that is the case in your series?
I'm not sure.
Okay. Okay.
Yeah, you did immunohistochemistry in 24 cases. Was it suggested by the pathologist, or you
yes, sir.
took the decision?
At the discretion of the pathologist.
At the discretion of the pathologist.
Yes.
Any more questions? Okay, thank you.
Thank you, sir. Thank you, everyone.
So next we have Dr. Bimal Balu, who's going to be presenting on functional outcome of acute versus delayed presentation of perilunate dislocations. This is a retrospective single center study.
Good afternoon all. I'll be talking on functional outcome of acute versus delayed presentation of perilunate dislocations, a retrospective single center study. Perilunate injuries are uncommon yet challenging, constitute 7% of all carpal traumas. Often misdiagnosed, they are treated suboptimally in approximately 25% of cases. Late presentation typically have a poorer prognosis compared to early presentation. A study in 1993 defined 3 phases of presentation in perilunate injuries: acute, delayed, and chronic. Delayed phase was taken up to 45 days as it defines the end of second stage of ligamentous healing. In a study comparing early versus delayed treatment of perilunate injuries, it was found out that early treatment has a better prognosis compared to delayed treatment, in which all the cases underwent open reduction and internal fixation. In a systematic review in 2022, it also concluded the same, that acutely treated had a better prognosis compared to delayed treated, and in acute presentation, open reduction had a slightly better close reduction had a slightly better outcome compared to open reduction, and majority of the delayed presentation was due to misdiagnosis or polytrauma. Hence a gap in knowledge. Why there is delayed presentation in perilunate injuries in our population? Does close reduction have a role in delayed presentation cases? And does standardized management strategies differ in delayed cases? The aim of our study was to assess the functional outcome of acute versus delayed perilunate injuries. And our objectives were to assess the difference in outcome of closed versus open reduction in delayed presentation cases, patient-rated hand rest evaluation score, and modified Mayo risk score. We conducted a single-center, case-controlled retrospective study from 2016 to 2023 on adult patients of perilunate injuries presenting within 45 days of injury. All perilunate injuries who underwent operative management were retrospectively assessed. Their type of treatment and reason for the same was obtained from the medical records. They were followed up with plain radiograph, grip strength, range of movement, PRWHE score, and modified Mayo score. Our statistical analysis, we used independent 2-sample students t-test. We had 20 patients in acute presentation and 18 in delayed presentation. Out of the 18, the most frequent reason for delay was delay from the patient side. Out of the 20 in acute presentation and 18 in the delayed presentation, the groups were comparable in terms of age, site involved, gender, and average follow-up. The average duration from injury to surgery in the delayed presentation group was 17.4 days. Out of the 20 in acute and 20 in the acute, 8 underwent closed reduction, while the rest 12 underwent open reduction. The reasons for open reduction were comminuted scaphoid base fracture and or lunate comminution. Out of the 18 in the delayed presentation, 6 underwent closed reduction and rest 12 underwent open reduction. In the functional outcome of acute versus delayed group, the groups were comparable in terms of flexion extension arc of movement, grip strength, PRWHE score, and modified Mayo score. But the acute presentation group had a slightly better outcome compared to delayed presentation group, but it was not statistically significant. In the delayed presentation, when comparing open versus closed group, the groups were comparable in terms of flexion extension arc of movement, grip strength, PRWHE score, and modified Mayo score. But the closed group has slightly better outcome, but it was not statistically significant. This is an 8-day-old post-injury patient who underwent open reduction. This 2-year follow-up. The 15 days post-injury who underwent open reduction. At 1.5 years, he was diagnosed with the scaphoid non-union and underwent bone grafting. This is 1 year post-bone grafting. 17 days post-injury who underwent closed reduction. This is post-fixation. This is at 2.5 years. 70 days post-injury patient who underwent closed reduction at 1.5 years. The 32 days post-injury who underwent open reduction, and this 2-year follow-up. On comparing the previous studies on delayed presentation, all the studies open reduction was done, and in our study we were able to manage 6 cases with closed reduction and the rest with open reduction. We also had our fair share of complications in which 2 patients had non-union which required secondary bone grafting and 1 patient with infection requiring revision procedure. We had no cases of AVN. The strength of the study was, it was the largest single-center study comparing acute versus delayed presentation with both objective and subjective scores being calculated. Our limitations include a variable timeline on follow-up. On conclusion, there was no statistically significant difference in the range of movement or grip strength in the cohort of acute and delayed. The patient rated and the objective scores were also comparable. Delayed management in our setup was due to late presentation by patients. Closed reduction has a role in delayed management. Thank you.
Any questions from the floor? Maybe I'll start. Most studies seem to show the delayed presentation give a poorer outcome, but your study is a little bit different. Can you suggest some reasons why?
Yes, sir. It was not statistically significant, but there was a comparatively better outcome in the acutely treated group. But it was not statistically significant in our group. That's why we did.
So you're saying that if it's a sample size issue?
Most probably so.
But having said that, I didn't look at it that closely, but the numbers were not that different actually. I thought.
Pardon me, I didn't get the question.
I think the differences may not be that stark. But maybe I will hand it over to the next question.
Yeah, thank you. In the delayed presentation group, was the reconstruction done at the same time? Did you attempt a ligament repair at the same time?
Yes, in some cases we did, sir.
In some cases?
Yes.
Was it accounting to a better outcome?
No,
because,
sir.
Normally, because what he asked, obviously the acute presentations, closed reduction should give a better result compared to your delayed presentations.
Yes, sir.
So according to your assessment of instability in delayed presentations, how long was from the injury to the average surgery?
The average duration was 17.4 days, sir, of delayed in the delayed presentation group.
17.4 days?
17.4 days.
That
yes,
is
sir.
2.5 weeks?
Yes, sir.
Okay. So how many cases you have done the ligament reconstruction?
In 4 cases we did ligament reconstruction, sir.
Okay.
So Bimal, your criteria for saying delayed presentation is how many days?
Pardon me,
your
sir?
criteria for saying it's delayed presentation is how many days?
From 7 to 45 days, sir.
To 45 days?
Yes.
Okay.
It was according to the study in 1993 by Herzberg.
Okay. So in those whom you are able to do close reduction,
yes, sir.
Why do you think what they're shorter duration or longer duration? What's the reason? Some you can do closed, some you could not do closed.
Sir, in the patients who presented in that close reduction group, one patient had hyperligament laxity. So that might be one of the reasons for close reduction in that case. Other two were pure perilonate dislocations, and other three had some sort of plaster applied from outside the hospitals when they presented to us. So the swelling, because of the less swelling compared to the other cases, we might have had lung infection.
Sure.
Okay, thank you very much.
Thank you.
Thank you, Bimal.
So last but not least, we have Dr. Paraj speaking on comparison of the clinical and functional outcomes of two different immobilization protocols for TFCC repair.
Good evening, everyone. I'm presenting a randomized control trial on comparison of clinical and functional outcome of two immobilization protocols after arthroscopic peripheral TFCC repair in adults. Peripheral TFCC tears are amenable to repair by arthroscopic or arthroscopic assisted procedures and are considered standard treatment of choice. However, there is no gold standard rehabilitation regime following TFCC repair. A recent scoping review which was published showed that the commencement of range of movement after arthroscopic TFCC tear varies between 2 to 12 weeks irrespective of the type of repair or the stage of ligament healing. Similar to any vascular ligament, the TFCC also undergoes through three distinct yet overlapping phases of ligament healing. Mobilization during the stage of inflammation has contraindication as a side effect of excessive hematoma formation and stress at the repair site. During the stage of proliferation, the collagen aligns along the lines of stress, which is advantageous. However, abnormal forces acting during this time can cause ligament laxity and re-rupture of the repair. The stage of maturation is considered safer for initiation of mobilization due to the presence of stronger ligament, but at the cost of joint stiffness. Another study on the healing of TFCC has shown that rapid improvement in functional outcomes occurs up to 6 months, after which it declines to reach a plateau. Thus, this study is designed to determine if mobilization in two different phases of ligament healing has a bearing on outcome at 6 months. We aimed to compare two immobilization protocols of 3 weeks and 6 weeks for clinical and functional outcomes after arthroscopic peripheral TFCC repair. Based on the review of literature, we presume the null hypothesis that there will be no difference in the clinical and functional outcome between the two groups. Clinical outcomes in the form of foveal test, Bellotment test, and objective tests like weighted press test, VAS score, grip strength, and range of movements were recorded. And functional outcome in the form of MMWS and PRWHE scores were used. So this was a double-blinded randomized controlled trial conducted at a single tertiary care center between February 2023 and August 2024 after obtaining adequate clearances and registrations. And this study was conducted in accordance with the CONCERT guidelines. So adult patients presenting and diagnosed with peripheral TFCC tear and presenting after a period of non-operative management were included in the study. Of them, irreparable foveal tears and patients with associated conditions which hamper the rehabilitation protocol and patients not willing to be a part of the study were excluded from the study. A total sample size of 32 with 16 in each group were calculated with CI of 95% and 80% power. Statistical analysis, the data was represented adequately. Mann-Whitney U-test and Wilcoxon sign rank test was used to test the statistical significance. So the patients who were enrolled for the study were preoperatively assessed for clinical and functional outcome scores. Then the patients who are blinded by the randomization are categorized into two groups by 1:1 block randomization as computer generated. Then arthroscopic TFCC repair is performed by a single surgeon who is also blinded by the randomization. After the surgery, all the patients were put on a above elbow cast with elbow in 90-degree flexion, forearm in semi-supination and wrist in neutral position for 3 or 6 weeks according to their group. After that, a removable Munston splint was given for 3 more weeks with initiation of graded rehabilitation. So during the rehabilitation period, the first 3 weeks we aimed at pain and edema control by introducing mirror therapy, active range of movements of wrist and forearm, and isometric exercises of secondary stabilizers of wrist and forearm. During the next 6 weeks, we aim to regain the total range of movements of wrist and forearm in these patients, along with strengthening of the same group of muscles. By 12 weeks, our aim was to teach specific exercises for apprehensive movements, along with introduction of palm support and plyometric exercises. So patients of both the groups were followed up at regular interval, and at 6 months, they were assessed finally for primary and secondary outcome. In results, there was no statistical difference between the demography, the type of tear or the type of repair between the two groups. In the intra-group analysis, the post-operative scores improved significantly in both the groups and were statistically significant. In the intergroup analysis, to our surprise, we found that the 3-week immobilization group had better scores and was statistically significant. There was no harm or unintended effects noted in both the groups because of the intervention. Though we did not find relevant basic science studies on TFCC, the relevant studies was found on the knee joint which justified our results. One study on the meniscal healing showed that the collagen content reduced proportionately to the period of immobilization. However, this was not significant up to 4 weeks of immobilization. Another study on biomechanical properties showed that the stress deprivation rapidly and strongly reduces the mechanical properties of the ligament in time-dependent manner. And to regain this mechanical strength, the period of rehabilitation required was directly proportional to the period of immobilization. Another study on failure of load to failure in healing ligaments showed that the 6 weeks and 14 weeks immobilized groups failed more than the 3-week specimen at 10% of creep phenomenon. Hence, they emphasized the need of protected mobilization during this phase. Thus, concluding my study, the 3-week immobilization group had better clinical outcome than the 6 weeks group at 6 months, thus rejecting our null hypothesis, and protective and gradual mobilization of the repaired TFCC had favorable outcome. These were the strengths and limitations of my study. Thank you.
Thank you very much. Open up to the floor for any questions. Okay.
Thank you for a very nice. Please. Thank you for a very nice study. I think in this series they were patients that did not have instability. Is that correct?
We included both, sir, but the proportion of patients who didn't have instability was more than the patients. The patients who had instability was less compared to the patients who didn't have instability.
Do you think if you had a larger series that the patients who have instability may be different from those who do not have instability?
Yeah, maybe another study to compare those two.
Okay. And just one thing, you quickly ran over the slide of the results. What were the clinical outcomes that were better in the short rehabilitation? Was it all factors?
Okay, I'm not able to play it, but clinical outcomes, the grip strength and pin strength, improved significantly, and we consider weighted press test for our primary outcome. That was also significantly improved.
Okay. Next question, please.
So, thank you. Has your practice changed after this paper?
It will, sir. As of now, we are mobilizing for 3, and we didn't have a proper strict regime. So maybe after the study it will change.
Another factor which makes a difference to the study is about
instability.
That will make a lot of difference.
Yes.
Okay, maybe the last question from
good evening.
Number 4.
Were both groups of patients operated?
Yes.
So were their rehab protocol different for the 3 weeks or the 6 weeks?
No, the rehab program was the same.
Okay, perfect. We're just out of time. Thank you very much.
Yeah, we conclude the session for best paper presentation. Thank you very much for coming, and have a good evening.